Right, so can everyone see that? Beautiful. Okay. So what we are going to cover today for our CPD is going to be tips for success. So working as an NDIS funded psychologist, I am going to obviously be presenting this session at the moment, and then Ashley Byrne's going to be presenting the session in around 3 hours time, depending on what location you are in. I guess that is going to be dependent on what time it is. So don't ask me to map it this morning. As always, in the spirit of reconciliation, I acknowledge the traditional custodians of country throughout Australia and their connections to land, sea, and community. I'd like to pay my respect to the elders past and present and extend that respect to all Aboriginal and Torres Strait Island peoples today. I'd also like to acknowledge the individual and collective expertise of those with a living or lived experience of disability, and note that we can only provide quality care through valuing, respecting, and drawing from this expert knowledge. This is just a little bit of a safety briefing as well, based on the nature of this session and the fact that we will have a little bit of an interactive component in it. As per the Med Health Safe Practice Policy, if you are currently driving or in a situation where you're not able to go into the chat, then please make sure that you join into the later session. There's absolutely no need at all to join in now if it is not safe for you to do so, okay? So please just make sure you consider your surroundings and your safety at this current time, and switch off now if you are driving. And then you can join us later. Beautiful. We are also going to do a reactive feedback right at the end. Obviously, throughout the chat, you are more than welcome to pop in any things as we go through. You'll probably notice that there is a prompt during this presentation that asks for that. But obviously, as we go through, or any questions, then please feel free to pop them in the chat. Otherwise, we'll hopefully have some question time at the end as well. So let's get started. We are going to go through some tips for success and what does this look like to be a psychologist within the NDIS space, because it can be a little bit different. So the first tip is going to be having clarity on what psychology work in the NDIS is and isn't. So an NDIS psychologist aims to support participants to achieve their goals by improving their functional capacity. An NDIS psychologist will engage with the participant and their stakeholder system to gain an understanding of the current cognitive, emotional, or behavioural blockers, preventing NDIS goal achievement. We'll also develop and implement an evidence-based and individualised intervention plan designed to improve the participant's functional capacity and facilitate their NDIS goals. So in doing so, the participant can overcome their barriers and achieve their NDIS goals and well-being. This is a slightly different framework to the mental health treatment model that psychologists use in other organisations as well. What do we not do? So NDIS psychology is different from the typical psychology model. We won't actually complete diagnostic assessments for participants. We're unable to provide treatment of mental health conditions, and we're unable to address concerns considered to be separate to a disability. So such things as substance use, long-term risk and crisis management, and trauma. Obviously, there are great organisations and great models that are out there that are supporting these areas. It's just not something that the NDIS currently supports as well. Our second tip is going to be around knowing your client. So NDIS psychology participants are very different from typical psychology clients. So they could have complex presentations, so more often than not multiple diagnoses, living in a state of flux or crisis, lower literacy level, some memory and language concerns, distressed and in discomfort, institutionalized, my goodness, and have been a psychology client for many years. And they might have multiple healthcare appointments per week. More often than not, NDIS psychology participants present with self-determined goals that are the required focus of intervention. And then they also present with really large systems of professional and non-professional stakeholders. So this necessitates both a systemic focus, but also an MDT lens. And then have an intervention length, which is determined by their funding amount rather than need. And then require reports completed by the participant in mind, but written for the NDIS. This kind of leads into our third tier. So talking around, what is this going to look like for our participants as well, is making sure that you're adjusting your therapeutic style for the population of our people. So given the nature of the NDIS cohort, several adjustments to the usual psychological practice need to be made. I am going to get you guys to pop in the chat if you can think of any changes that we need to kind of consider or make when it comes to supporting our NDIS participants, and the ways that you would actually provide, support. I can't see the chat until afterwards, so that's going to be fun, but we go through them after anyway. So if you want to just pop anything in there or not, totally up to you. Yeah, cool. Any others that you guys can think of? Yeah. Amazing. So we are going to have a look at some of the different ways. Sorry, Julia, hold on. I have clients who are uncomfortable with technology, so laptop has to go away. Yeah, that's a really good consideration. Let's go through some of these changes and how it's going to look slightly different when it comes to the way that we're delivering sessions. So things that we might need to consider and alter. So these are going to be some of the more common adjustments which we need to make to support our participants. So we've got to consider like the frequency of sessions, right? So sessions may be most successful with a regular day and time, so participants can establish their own routine. We also might need to conduct our sessions on a fortnightly basis, so participants don't forget the strategies and skills during long gaps between sessions. Sometimes, typically, we see sessions occur on a monthly basis for some participants. They take their skills away and they're able to go and then implement those strategies. Oftentimes within the NDIS space, we see them the frequency to be more on a fortnightly basis, less time in between, making sure that we're following up with their practice of each of those skills. And we actually might even need to alter the number of sessions and increase those, which means that we're going to go at a slower pace and have a chance for consolidation. So I always think about what Dr. Emma says here in these situations of like that hasten slowly, which I think really applies here. That maybe we're not trying to achieve so much in our sessions anyway. We're going to go a lot slower, more bite-sized, manageable pieces for the participant and the stakeholder system to be able to implement. We also might need to consider our session lengths. So we might need to alter them, and these may need to be balanced between being long enough to allow for a slower pace, however short enough that participants can stay engaged. So sometimes we might find that a 30-minute session is going to be more useful for our participant to fit into their day and with their attention spans, compared to trying to stick to that typical 1-hour model or the 50-minute model where we're really trying to extend or draw out and everyone just loses focus. We're trying to bring them back every single time that we're delivering our intervention. Sometimes as well, we might even have to increase our session length, because we're trying to implement things with stakeholders as well, maybe towards the end, or we want to give it enough time to sink in and practice. We maybe also need to alter our clinical tasks. So, like I was saying before, with our intervention, maybe we need to make them a little bit more of a bite-sized chunk that people can walk away with and understand. We might need to give them an opportunity for more consolidation and practice before moving on to the next intervention phase, right? We might actually need to, rather than it being 6 sessions, it might take anywhere between, up to 10 sessions for something to really stick and we start to see the progress with it. We may also need to consider, what skills does this participant have and how much written work can they do? So are we relying a lot more on the visual aspects rather than it being written worksheets and, having those things that we go through? And then we may also need to be able to understand, and we will need to be able to be understood and supported by the stakeholder system. So knowing that this participant isn't going to be the only person implementing some of these strategies sometimes throughout this participant's life, there might be a really good stakeholder system that also is able to be around and help. So this kind of leads into, typically we wouldn't actually see others present in psychology sessions, but we might actually need to include a supportive stakeholder, all right? So obviously with the participant's consent, so they can actually support the participant with implementation between sessions, right? This is going to be a safe person and also someone that can check in and make sure that they're giving strategies a go as the weeks are going in between. External support. So sometimes clinical strategies or tasks will require the stakeholder system in order to be more successful. So it also means that we might actually need to do some more communication and possibly training for those stakeholders. So how can we upskill the stakeholder network that is around this participant and turn them into their own mini psychologists to help that participant through those times, right? To make some to make some decisions to help support that participant and teach them about what certain signs and symptoms might look like for each person, how to implement certain strategies and things that way. We also need to really consider the available funding. So sometimes an intervention plan needs to be tailored to not only meet the NDIS goal and the needs of the participant, but also to be effective within the funding constraints that are present. All right. So sometimes it's about being clever and considering bang for buck. We've also got to consider our treatment sequencing. So at times an intervention plan may need to address urgent clinical needs first. So we're thinking about risk and report writing before the actual treatment can kind of occur. Which leads into kind of our 4th tier, which is going to be get close, personal, and comfortable with functional impact. The functional impact conundrum. So one of the hardest things for psychologists working with NDIS participants is conceptualizing and reporting functional impact. The NDIS focus on functional impact is different to the diagnostic way psychologists usually think about clinical presentations. So NDIS weighs functional impact more heavily than qualifying for a diagnosis or diagnoses. While signs and symptoms are considered in both approaches, functional impact and the way in which a disability affects a participant's life is required for NDIS reporting. So this requires NDIS psychologists to think beyond diagnostic criteria and write reports in an unfamiliar way sometimes. So understanding the terms. It's important to understand the functional deficits and functional impacts of psychosocial disability. So functional deficits are the signs and symptoms a person experiences as a direct result of their psychosocial disability. So if we consider things like low mood, intrusive thoughts, or hallucinations for someone who has schizophrenia, your functional impacts are going to be the consequences of those deficits on a participant's daily life. So unable to self-manage. So we're actually going to explore a little bit more of that schizophrenia example and just unpack it a little bit further. So deficits as a result of schizophrenia can vary widely between widely between participants, or wildly, However, commonly identified functional deficits include difficulties with memory, thinking clearly, making decisions and plans, understanding people's emotions and motives, communicating needs, and making and keeping friends. These functional deficits of schizophrenia can lead to significant functional impacts for some participants. So these functional impacts include inability to self-manage, which requires supports to maintain self-care, well-being, and community participation. Difficulty understanding others, which impacts on the ability to form and maintain relationships with others. And difficulty advocating for themselves, which impacts on well-being and ability to access support to have needs met. Difficulty making and keeping friends, which impacts on meaningful social and community participation, which requires significant support. So in a nutshell, it's not enough to say the participant has a diagnosis of schizophrenia and has trouble telling the difference between real or hallucinatory stimuli. NDIS would say, how is that the NDIS problem? Right? So we must spell out how it is their problem and how each participant needs additional support. So we're going to take that first sentence and we're going to say the participant has a diagnosis of schizophrenia and has trouble telling the difference between real or hallucinatory stimuli, which then results in a difficulty behaving within limits accepted by others, which impacts on their ability to form and maintain positive relationships and successful community engagement. Right? So this is what the NDIS is really wanting to see in terms of those funding streams as well. So let's have a look at a clear working process or formula for functional impact thinking, which is going to be a little bit more helpful. You've got to make sure that you note the diagnosis. So this is going to help us guide our search for the functional difficulty being experienced. List the functional difficulty or deficit across each psychosocial domain. So highlight all the ways in which this diagnosis affects the participant's life and the difficulties it creates for them in each domain of psychosocial functioning. And highlight the functional impact. So explain how these difficulties or deficits impact on the participant's life and why that is a problem. Okay. So support recommendations is going to look at once the functional impact has been spelled out, it is also a lot easier to make support recommendations because the need and reasoning is clear. This includes additional funding to continue intervention sessions, as well as recommendations for additional funded and non-funded supports. That leads us into when we're thinking and considering a lot of our report writing obligations, right? So we're going to make sure that we're staying goal focused, which is another really big area of focus within the NDIS and going to be your fifth tip. So NDIS goals. Although a participant may present with a psychosocial disability and associated functional deficit and impairment, we can't jump into working on their presenting symptoms. We really have to make sure that we work towards their NDIS goal achievement. So NDIS and intervention goals. NDIS interventions need to target achievement of a participant's NDIS goals through capacity building and skill development. So this could be focused on teaching and implementing skills the participant needs to reach their goals or improving their capacity to manage emotional, cognitive, behavioural blockers that are preventing goal achievement. So the clinician and the participant need to discuss the current NDIS plan goals and together determine what psychosocial intervention focus will assist the participant to achieve these. From there, the clinician needs to develop intervention goals which guide the work that they do. There is actually a section at the bottom of the initial clinical assessment template, which helps support that and is also a really, really good tool to make sure that you're gathering the NDIS goals at that initial assessment, then also sitting down and being able to figure out, how can we relate back to these goals? How can we deliver an intervention that is, tapping into what is needed? So it's all really, really clear, which is then going to actually help you in the long run, where you have to write your progress reports or letters of support or things like that, that are you've already done the hard work, right? So I really recommend making sure that you kind of complete that. And if it's not at the initial assessment, then making sure that you complete it within one of your first sessions with your participants. It's also going to help you when it comes to that treatment planning and your intervention plan that is kind of required on a lot of our files. Just as a little insider tip. Okay. So intervention goals. This is what makes intervention goals really important. To drive an effective intervention goals need to be collaborative and smart. So examples of these for psychosocial disability might be, over the next 3 months, participant will be able to re-engage with their day program once a fortnight. Or over the next 3 months, participant will be able to implement regulation strategies with assistance when prompted. Or over the next 3 months, participant will be able to communicate to their supports how they are feeling with prompting. Tip number 6. We've got to consider the system, like what we were talking about when it came to how we need to alter our sessions. So within the NDIS, and especially from that psychological perspective, we work a lot with a system around or a network around a participant as well. So why is it important in NDIS work? So NDIS participants are often at the center of complicated systems. So include both personal and professional stakeholders. Systems can be large with many stakeholders, and stakeholders are often from many different organizations. Systems may have no clear lead stakeholder, and as such, systemic processes may not be running well or at all. And without clear communication, stakeholders may be working directly in contrast with each other. So if we kind of add all of this together, what this can result in is really like poor support for that participant. However, there are simple ways that we can stay abreast of this. If we use the focus, or if we start to look at eco maps, an easy way to understand the system around a participant is to complete an eco map. So similar to a genogram, but it's a little bit simpler and takes on a broader view. An eco map is going to include organizations and lead figures, highlight relationships and engagement, specificity to ensure it's complete, and then can be professional only eco maps or full eco maps. So you can just focus on, who is in that participant's life from a professional perspective and be able to identify, highlight any gaps there. Or you can look at the whole eco map of informal and formal supports, as we would say. So this is going to start looking at, why is it important to have like a lead stakeholder? And it's actually really important to have a well-functioning system, a lead stakeholder to have a well-functioning system. So within NDIS systems, the lead stakeholder generally is the support coordinator. However, this is not always the case. The lead stakeholder has some key tasks to ensure the stakeholders work well as a team. So this is going to include onboarding new stakeholders, creating and running a communication plan, scheduling and running stakeholder meetings, identifying systemic barriers to goal achievement and resolving these, and ensuring the participant's voice is heard within the system. Communication. So large and complex NDIS stakeholder groups invite silo work. This invites risk of working in contrast to one another or preventing group facilitation or goal facilitation. Effective communication within the system can overcome this easily, and this can actually include setting an expectation that all stakeholders are active in stakeholder tasks because their contribution is invaluable. Stakeholder contact lists, which are kept accurate and regularly shared, highlighting the role of all stakeholders and noting the value of this to the group. Regular roundup emails to the stakeholder group sent by the lead clinician, and presentation of a treatment plan to all stakeholders at a stakeholder meeting to invite all clinicians to do the same, and getting face-to-face when you can. I think this is probably one of the areas a lot of the time where, there can be so much changeability that happens within the NDIS space for a lot of our participants. And one of the areas that we can, although it's not necessarily our main role, but we can help the support coordinators or those around to really understand how it's going to be important for the participant and for them to achieve their goals. So something that we can help others see. So what that is going to look like is regular stakeholder meetings can be crucial in building connection, facilitating communication, and implementing intervention. So these can often be full or professional only stakeholder meetings, and the difference between the two can be significant. So regular meetings guided by an agenda can be an invaluable systemic intervention. The function of stakeholder meetings can include determining a collaborative solution to a current issue, simple but effective communication regarding a concern or issue of note, building collegial relationships, ensuring stakeholders are working in an aligned way, and maintaining accountability for intervention and support plans. For me, I've actually found that regular stakeholder meetings with a lot of my participants are really important to having people all on the same page as well. Participants can say certain things and go throughout their care and say this person hasn't turned up. But if we're all making sure that we are on the same page and we can understand who's going in and who's responsible for what, I think that's a really, really important level of support for each of our participants as well. It just helps them have some consistency and knowledge around who's in their care and who's also making sure that they're doing their work or what they said that they'd be doing. So in the work that we do, having stakeholder support can actually really greatly improve intervention outcomes. So sometimes we can't assist a participant to achieve their goals without help. This means that understanding who is in the system and building connections with them can be very important. We may actually need to reach out to the system for help with risk monitoring and safety planning, implementing therapeutic strategies, and data collection. And I've actually had to do all of these with multiple different participants across, my time as a psychologist in this space as well. And so it's sometimes really important to making sure that you're upskilling some stakeholder members, especially when it comes to risk. What steps that they need to take, how can they help and support each of the participants when it comes to, I think of things like mindfulness and relaxation and everything like that. And then also if you're trying to look at data or even, behavioral activation kind of focuses, getting someone to actually feel like they're mastering a bit of a skill. Tip number 7, writing for the NDIS. I feel like this is always a really interesting one to kind of cover off and talk about as well. So NDIS writing, the NDIS requests and requires a really specific writing style preference. It is often really deficit focused and highlights what the participant cannot do or still needs help with. Is functional capacity and goal focused rather than diagnostic, and then must demonstrate a clear connection between function, behaviour, symptoms, and NDIS recognised diagnosis. Therapeutic reviews do note improvements, but focus more strongly on what still cannot be achieved or still needs to be achieved, and is written objectively and factually with NDIS as the reader in mind. So the participant and family will see the report through those. So we need to really consider that it can be be as person-focused or person-centered as possible, but also considering some of the information that is included in a report, especially noting that, we've got to combine a couple of different preferences, with what the NDIS requires and what they want to see, but then also considering who might actually see this report. So unfortunately, what that leads to is that this style, mismatches results in psychologists, and we often feel uncomfortable with the less therapeutic NDIS writing style, and they either avoid using it or soften it. Okay. So the consequence of this is going to be ongoing treatment needs not being justified by enough ongoing disability or deficit. And as such, funding is either not renewed or is cut, especially in this psychology space more recently. I think there's been a lot of big debates that have been occurring around, what that looks like, and psychology not necessarily being as well funded as it used to be. And so the other consequence is going to be that participants do not then get the care they need, and psychologists are inadvertently causing harm rather than care. I don't know if anyone else on here has also experienced something similar where, funding, especially for psychology, is maybe not necessarily renewed, or, planners just don't see as much of a benefit in psychology as what we kind of originally intended. So I think NDIS writing styles and the importance of how we write can be really, really vital in making sure that they get their ongoing care. So how do we work through this? As a discipline, we just need to make a few slight changes. So we need to alter our writing style slightly, clear, concise, factual description of the disability. We also need to make sure that we read as many example reports as you can to acclimatise to this style. Have an NDIS congruent template to follow when reporting. So this is where all of your AAA psychology templates are congruent. So making sure you use those. And then upskill in conceptualizing and reporting functional impact, like what we were talking about earlier, and how this links to intervention goals and support recommendations. So there's actually lots of resources available for AAA clinicians to improve both their report writing competency and efficiency. So while not psychology specific, these are actually extremely helpful at shifting towards an NDIS writing style. And these include, but are not limited to, gold standard report templates for all disciplines, audio walkthrough of different report templates, which provide hints and prompts, and then the QA podcast, which does a deep dive into different aspects of report writing. And you can actually see if you want to find any of these resources on the intranet. I have smashed through this. Tell me I talk quickly without telling me I talk quickly. Anyway, what I'm going to do is, this has obviously been brought to you by Clinical Excellence. They always love your feedback, which means a lot to them. So you've got your Clinical Excellence email at abilityactionaustralia.com.au to send through any feedback. Otherwise, I'm also going to put a feedback react in the chat as well that I would really appreciate you guys completing if you can. I'm going to jump off recording and stopping sharing my screen, and then we've got any questions that we can do as well. So give me 30 seconds to figure all of this out.